more interprofessional learning for you. This is in response to some feedback that the website has already received. So I was going to give you a more individualized approach to the facilitator's role in interprofessional interaction and expand upon the process portion of the 3P model just a little bit. So I hope to answer a potential role of the facilitator in interprofessional learning. In the last slidecast, I discussed the 3P model and used the London and CESA model as a highlight the highlight of the process aspects of interprofessional collaboration. Some of this may seem kind of obvious, but I think Steiner put it best in her review on interprofessional learning and faculty development is that one of the roles of the facilitator in interprofessional collaboration, interprofessional interaction is simply to make the implicit explicit. And a lot of that has to just do with good behavior between human beings, or as Dr. Hammock notes, just having mutual respect for the other professions and your colleagues. So we'll start with a case, a fictitious case, we'll say, in an intensive care unit, where a senior nurse is helping a colleague of hers adapt to a new technology in the ICU. And this technology is new to the ICU. It's something that's come in vogue in the last 5 years or so. And it's continuous Doppler flow monitoring in response to a passive leg raise in a patient to determine if the patient's heart is fluid responsive or not. As the senior nurse is talking to her colleague about the underlying physiology and reasoning for this new technology, an older physician walks by. He looks up at the two nurses in discussion. He rolls his eyes and states with a sigh, "Another medical fad which will fade away in a few years, just like the Swan-Ganz catheters before it. I don't know why you're going through the trouble." And he strolls out of the intensive care unit with an air of sagacity. The two nurses continue the discussion, and the novice nurse looks up and asks, "So wait, how do I position the patient again?" So in any sort of group interaction, we'll consider the two nurses and that physician there a group interaction. There's a transition and preparation process. And this was I first came across this in a model proposed by Marx in the early 2000s, where there's this notion of these episodes of cycles of behavior between human beings that begins with these transition processes that are essentially, the transition is analysis, goal specification, strategizing, planning. It's basically just getting everything ready to go. And then you essentially start collaborating, working together. There's then the action and engagement process where you're monitoring, you're coordinating, you're activating, and you're working through your objectives. And the third part of the model is that this transition is actually mediated by interprofessional, or rather I should say interpersonal interactions. And this can either be a good thing or a bad thing. And they were described, these interpersonal interactions were described in the 1950s by Bales as amalgams. And so positive interpersonal interactions will facilitate people working together, whereas negative interpersonal interactions or amalgams will inhibit the action and engagement processes as you're working as a group. And so as you move through this pathway, you're trying to reach your ultimate goal, and here it's implementing the new passive leg raise with continuous Doppler flow in the intensive care unit. That's the ultimate goal, to introduce a new physiology, to learn something about a patient's heart. So certainly as a champion or as a local master or facilitator, one of the first things that you need to do to enhance interprofessional collaboration, learning, education, is that you need to make the implicit explicit. You need to recognize these interpersonal cues and what's going on between people, and you need to reward the good, and you need to gently deter people from the bad. So I think in that case you could get a sense of what a good and a bad interpersonal interaction was. But what may be a little bit less obvious, and this is getting more into the London and CESA model is that the facilitator needs to also identify the triggers for learning in the group stage, the group goal. So here, in the case that we just discussed, perhaps the trigger for learning was this implementation of the passive leg raise and Doppler flow monitoring. And then the facilitator needs to gauge where the group is at in terms of their goal. Is the goal, as it usually is at the beginning, just kind of dealing with learning a new technology? Or is it trying to master material and develop new ideas? So, in that case, the senior nurse was teaching the junior nurse. The junior nurse was kind of in an adaptive stage, as London and Sessa would say. They're trying to react to the new information that's coming to them. That junior nurse is not at the stage where he or she would need to start developing new approaches to this implementation. So in the early stage, the facilitator needs to check the goal, and if the stage of the group, the stage of the ICU in the situation is just to learn any technology early on, the facilitator needs to match the trigger and the goal of the group to the interactions that develop. And here it's feedback and motivation, and this is called adaptive processes or adaptive learning situations. And the facilitator needs to match the two, because you could imagine that if the facilitator tried to start brainstorming and coming up with generative ideas when the group is new and just trying to learn the basic stuff, it's not, the interactions are not going to go very well. As the group proceeds and learns more about the new technique, learns more about the new physiology, has more experience, and starts encountering novel problems, and they need to start generating new information, well, then the facilitator needs to recognize that, and then they can start engaging in these more generative learning processes or generative learning interactions. And that's things like where the facilitator will help the group reflect and brainstorm and kind of provide a safe space where people can multi-voice, the group can multi-voice to better achieve their goal. There's an entire additional kind of interaction called transformative per the London and Sessa model, but I've left that out. So hopefully this diagram can give you a sense of the role of the facilitator in a specific case example of adapting a new technology to the intensive care unit. So here are the references. The Kozlowski and the Marks are two interaction models that are discussed in the London and Sessa paper there. And also I highly recommend the Steiner article from 2005. Thanks.